Dr. Achal Gupta will be talking on changing trends in the management of instability of lumbar spine in elderly population. Good morning.
Ma'am, can you see my presentation, ma'am?
Yes, you're audible. Your presentation is on screen. You can start.
Yes, ma'am. Respected chairpersons, today I am presenting on changing trend in the surgical management of instability of lumbar spine in elderly population. Introduction. In elderly patients, multiple level degeneration is common. Symptomatic patients not responding to the conservative management and progressive worsening neurologically require surgical management. Lumbar decompression in the form of laminectomy, liberal laminectomy, foraminectomy, etc. decompresses the cord and the nerve roots and provides relief to the patient. It also causes segmental instability and therefore it requires stabilization. Degenerative spondylolisthesis is also common in elderly patients. We have studied in our tertiary care center to analyze the surgical outcome in the cases involving the elderly patients more than 65 years of age who underwent three-level instrumented posterolateral fusion from the period 2016 to 2020 with a minimum follow-up of 1 year. Through midline approach, paraspinal muscles were split from the spinous process, pedicle screws placement were done, decompression was performed sequentially. If the patient had bilateral symptom, bilateral decompression and liberal laminectomy was performed. For all patients, a drain was placed routinely and the incision was closed in a standard fashion finally. Patients were allowed to ambulate on day 1 or 2 post-operatively and the drain was removed on the discharge on post-operative day 4 or 5. A standard lumbar bed was provided for 2 to 3 months after the surgery. This is a 65-year-old male patient with post-laminectomy status coming with a restenosis at multiple level. So we have performed the posterolateral fusion, 3-level fusion, along with a liberal laminectomy, and patient improved in the symptoms. This is a 70-year-old female patient with post-laminectomy status and the reduced disc space with multiple level restenosis. So we have performed the 3-level posterolateral fusion at L3, 4, 5, and patients improved in the symptoms. This is 72-year-old female patient with a multiple level reduced disc height, multiple level disc degenerations, and the lumbar canal stenosis. So again, we have performed the 3-level posterolateral fusion without the intervertebral cage fusion, and patient definitely improved in her symptoms. So we included 62 patients in our study, average age being the 69 years, and diabetes and hypertension is fairly common in these patients. We divided the group into 3 diagnoses: severe spinal stenosis with instability, 2-level listhesis, or 1-level listhesis with adjacent level stenosis, 1-level recurrent disc with adjacent level stenosis or recurrent stenosis. The most common level of fusion remained L3 to L5, followed by L4 to S1. So all the patients improved in the VAS scale, in leg pain and the back pain, ODI scale and JOA scale, post-operatively, and they continue to improve at 1-year follow-up. Radiological parameters were studied in the form of segmental lordosis, lumbar spine lordosis, and sacral tilt, and all the parameters improved after the surgery. Intraoperative studies remained with average operating time remained 200 minutes, with average blood loss remained 175 ml. So we had 4 cases of dural lacerations followed by the CSF leak. All were identified intraoperatively. So we closed the dura with Vicryl 40 followed by augmentation with muscle patch and the tissue solution. And no patient required re-exploration, and all the wound healed very well. We placed the drain above the muscle in case of dural lacerations. So there was one case of screw failure in which the middle border of the pedicle was breached by the screw, and it was irritating the nerve root. So it required re-exploration and the repositioning of the pedicle screw, of one screw. So there were 2 cases of adjacent segment degeneration, but both the patients were asymptomatic and didn't require any further intervention. Discussion. Degenerative changes in elderly lumbar spine patient causes spinal stenosis, listhesis, and fibrocartilaginous mass at the ischemic defect. Multiple level degeneration is common, hence it requires surgical treatment at multiple levels. Bone is osteoporotic, so unnecessary strain on the spine is not desirable. Multiple level degeneration is evident with reduced disc spaces at multiple level, opening of the facet joint at multiple level or dynamic studies, multiple level facial arthropathy, post-laminectomy instability, severe spinal stenosis, 2-level listhesis or 1-level listhesis with adjacent spinal stenosis, 1-level recurrent lumbar disc herniation with adjacent spinal stenosis. Pedicle screw fixation is one of the standard methods of instrumentation, advantage being the immediate rigid fixation, segmental control, and posture stabilization. So this study from Madurai, India clearly conclude morbidity and complications are much higher in patients undergoing the interbody fusion. And posterolateral fusion is recommended because the procedure is simple to perform with a lower complication rate and good clinical and radiological results. The fusion rates in both the interbody fusion and the uh, uh, intertransverse fusion were equal, and there were no increase in the pseudoarthrosis rate in any of the groups. So this study published in PMC further advocated there is no need for an intervertebral fusion because elderly patients do not seem to benefit from this procedure. And the intraoperative blood loss, need for transfusion, and surgical time are clearly reduced for elderly patients receiving the posterolateral fusion singly. So blood loss is more while placing the case, and sometimes the blood loss may reach to the 500 ml in the elderly population. In elderly, medical comorbidities lower the bone density, and plate sclerosis is common. Case subsidence rate or short segment fixation has more chance of failure. So my conclusions are in degenerative spine in the elderly patients, the intervertebral discs are degenerated, forming osteophytes and ankylosing deformity. The decompression and stabilization is the answer for these cases. In the elderly, when the whole spine is degenerated, trying to create space between the vertebra to put a case is not indicated really. Posterolateral fusion provides and promote arthrodesis, prevent non-union, and improve fusion rate. The third screw gives additional stability. Our experience over the 5 years has shown excellent results with these procedures. Thank you.
Thank you, Apurva, for the Achal, for that presentation.
Yes, thank you, ma'am.
I think it's an interesting topic. Any comments or questions?
Yes, thank you. How long was the follow-up for your patients?
The minimum follow-up was 1 year, but since we have started the study in 2016, so as of now we are having a few patients with 5-year follow-up.
Currently, as you know, follow-up should be about 2 years at least. Another thing is, what was the follow-up rate? How many of the patients you were able to follow up, and how many were lost to follow-up?
Yes, sir. So, sir, definitely this data I have to really find it out and really include in my study. But definitely most of the patients remain in the follow-up, and when we call them, then they definitely come. But still, I have not included in my study. So as of now, I won't be able to comment on it.
So again, the recommendation is typically at least 80% follow-up, because we know that people who have perceive themselves having a poor outcome may not want to show up or follow up because they don't like the surgeon or for whatever other reason, right? But that's important information for it to be high impact. And another thing, how did you rate outcome? Who rated the outcome?
So, in the terms of clinical outcome, we measured VAS scale of the back pain, leg pains, ODI, Osteoarthritis Disability Index, and JOA scale.
That absolutely should be presented in graphic form. You need to show your data. If you used all those scales, which is wonderful, it's very rich data. So it should be graphed. It's what percentage they did, what percentage did that. Because you have a large group, a relatively large group of patients with valuable results. It would be great.
I have it, sir, but the presentation was just for 7 minutes, so I didn't include. So to finish,
it's the most important data.
Yes, I will do.
Thank you.
Thank you, sir. Yes, sir.
Quite interesting, Achal. We are taken us back again. We have moved from a posterior lateral fusion to intervertebral fusion, and you are claiming now that posterior lateral fusion is better, particularly in elderly in this sub
elderly patients. Yes, sir.
What is the criteria for patient decompression is very important in this case. What is the reason why we do interbody fusion is not only just for the fusion, but also to widen up the intervertebral foramina there so that you release the nerve roots. In this patient, their foraminal stenosis is one of the commonest reasons why they get pains. So how do you achieve this in these patients?
So liberal laminectomy along with foraminectomy definitely relieves a nerve root from the bony compressions, which is most common in the elderly patients in the degenerative spine, and definitely with ankylosing spondylosis in the elderly spine, which is quite common, and so creating the space in that disc space which is already reduced and the bone is osteoporotic. So definitely it's not a good idea in elderly patients. So what we do, we put extra third screw to stabilize the spine, and then we stabilize the spine along after decompression of the nerve roots.
Okay, thank you.
Thank you very much, Achal.
Thank you, ma'am.